AVS Stenosis, a 2-year results and subgroup analysis by Dr. Charlotta et al. So my name is Jaewon Jung. I'm a 4th-year medical student at Georgetown University School of Medicine, currently in the application cycle to become an interventional radiologist. And Zuby and Harsha, you guys want to introduce yourself?
Hi, my name is Zuby Syed. I'm actually Jay's colleague at Georgetown, and I'm also applying within this ERAS cycle for interventional radiology.
Hi, everybody. I'm Harsha Voleti, a 4th-year med student at Northeast Ohio Medical University, also applying in this ERAS cycle this year.
And again, today for our faculty advisor, we have Dr. Nathan Frenk. To briefly go over his bio, he did his medical school and initial residency training in Brazil, followed by multiple fellowships at Mass Gen Hospital, including thoracic imaging intervention, abdominal imaging and intervention, and vascular and IR, and another year at Georgetown in IR. He's currently a faculty at the MedStar Georgetown University Hospital. If you could say hi, Dr. Frenk, just like.
Hi, everyone. Thanks for the invitation to be here.
Awesome. Before we dive into the article, I'm just gonna go lay some background information and some knowledge. End-stage renal disease affects more than 780,000 people per year in the United States. This disease disproportionately affects the minority and low-income patients, especially African Americans, not just because of the race, but the social economic status and the healthcare disparities that they face that we see in our country among this population. According to the US Renal Data System published in 2019, approximately 520,000 patients receive dialysis annually for end-stage renal disease in the United States. Again, ESRD affects many patients, but we can see that the incidence of ESRD has been flattening, as you can see on this curve, for a couple of years, but the prevalence of ESRD has been rising due to the increased longevity of the patient's lives, meaning that the things that we are doing currently are working. ESRD is an expensive disease where more than $30 billion are spent annually in the creation and the maintenance of dialysis. And what is the definitive treatment for ESRD? It is transplant, but getting a transplant, as we know, is like winning a lottery. If you could see this graph below, the dotted line is all ESRD patients. The blue is the patients with currently going under hemodialysis, and this darker orange line right here is a number of patients who receive renal transplants. So even though the definitive treatment is transplant, we have a long way to go. And we are trying to help this bridge gap as an interventional radiologist. So before they could actually receive the transplant, the things that we could do is dialysis. The types of dialysis are divided into 2 big categories: peritoneal dialysis, where patients receive this overnight daily, and hemodialysis. There are temporary access measures by providing catheters, or you could create a AV fistula or a graft. So today's topic is going to be focused more on the hemodialysis side. So again, hemodialysis, we have tunneled and non-tunneled hemodialysis catheters, which are usually in place until AV fistulas are created and it is matured for use. AV fistula is gold standard for dialysis, other than the graft itself, because the fistula itself has a longer longevity and patency and has lower infection rates. As we can imagine, having a foreign body inside the body creates more chances of infection. So AV fistula comes with its own set of complications. Infection, even though it is lower than grafts, it is still a possibility. Also, due to the increased blood flow back to your heart, you can get congestive heart failure or even have pulmonary emboli. So I would classify those as a more of a systemic problem. If you go into the particular AV fistula, vascular local problems, complications, you could get stenosis or even thrombosis. And you could also create pseudoaneurysms or cause aneurysms as well. So the stenosis distribution, it kind of varies based on the type of AV fistulas. The first one I'm going to talk about is a radiocephalic fistula. So you see all these numbers on this little diagram right here. These are all the, it's just a representation of the percent of stenosis where it is most commonly found. As you can see right here, the 64% at the site of the actual fistula formation is the most common site of stenosis in radiocephalic AV fistulas. In comparison, for brachiocephalic AV fistulas, it is, I would say, more commonly, more like distributed along the, I believe, the venous side of the circulation, 22% at the site of the fistula, 24, and then 30. So little differences between radiocephalic and brachiocephalic AV fistulas. And the one thing that I learned while preparing for this presentation is that about 25% or more of hospital visits of dialysis patients are due to vascular access issues. You need to be able to get great blood back and great pushability of the So let's say that you have a vascular access issue. What do you do next? You could always start with a physical exam, try to palpate for thrills, right? You could also order an ultrasound to see what's going on, and then also get a fistulogram to see what's going on. And let's say that you have a confirmed stenosis. So then what do we do next? We can do a surgical revision, a balloon dilation, like an angioplasty, or even endoluminal stenting, or any of these combinations above. So I think that was a good enough background to get through this article. So we will be talking about this article, Lutonix AV randomized trial of Paclitaxel-Coated balloons and AV fistula stenosis, a 2-year result. And Zuby will take it from here.
You can go to the next slide. Yeah, perfect. So the study hypothesis was to compare the outcomes of using a paclitaxel, which is a drug-coated balloon treatment after successful angioplasty of stenosis in hemodialysis fistulas versus angioplasty alone. This paper presents the final 2-year results comparing the drug-coated balloon versus conventional balloon alone. And if I could bring your attention to the drawing at the bottom of the slide. So the reason paclitaxel was used to coat the balloon was because it's usually a chemotherapy agent and it stabilizes microtubules within cells, which can lead to cell death. When used in this setting to coat a balloon, some studies have shown promising effects on preventing neointimal hyperplasia, which can cause restenosis. Next slide. So in this study, there was 285 patients enrolled across 23 institutions, and these patients were split between 2 groups to either receive the paclitaxel drug-coated balloon or the conventional balloon. And this study spanned a period of 2 years. All were blinded in the study except for the operator. Next slide. The primary endpoints of this study were target lesion primary patency at 6 months. What target lesion primary patency is the freedom from intervention for specifically revascularizing the target lesion itself. And in this period, it was in a period of 6 months status post angioplasty. The results to this endpoint at a 6-month period were already actually published by the authors, and at that point, at 6 months, showed no significance statistically or clinically between the two groups. The secondary endpoints of the study assessed TLPP again, access circuit primary patency, the number of interventions, and safety. Access circuit primary patency is the freedom from intervention to correct the entire access circuit or access circuit thrombosis. And this time frame was assessed every 3 months for a period of 2 years. Additionally, also analyzed was age, lesion location, and need for antiplatelet therapy. There was a vast amount of inclusion and exclusion criteria for the patients to be involved in the study, but mainly the patients had to be over 21. The AV fistula should be located within the arm and was to be created 30 days before the index procedure. The patients also had to undergo at least 1 hemodialysis session before this. Venous stenosis for inclusion within the target region was within anastomosis in the axillary or subclavian vein. Length of the lesion should have been 10 centimeters in length with a diameter between 4 to 12 centimeters. Stenosis measurement should have been greater or equal to 50%. And then during the dilation process, stenosis should have been successfully pushed to less than 30%. Next slide. Those that were excluded from the study were either pregnant, had femoral access, had more than 1 lesion in the access circuit, or had surgical revision of the access site within 6 months after the index procedure. Also excluded were patients who had contraindication to paclitaxel, had a less than 12-month life expectancy, were anticipating a kidney transplant, or had infection of the AV access site or systemic infection. Next slide. So patients that met the inclusion criteria were then underwent fistulography and had identified the stenosis via radiopaque ruler to measure the lesion. The percent stenosis was measured using the ratio of the minimal luminal diameter versus the reference vessel diameter. Since these sites are prone to aneurysm, it was decided that the reference vessel diameter site was to be measured at the nearest adjacent site that was normal and non-aneurysmal. Of note, early in the study, patients received balloon time for 30 seconds, but this was later changed to a balloon time of 2 minutes of inflation due to data that was coming out regarding drug-coated balloon and peripheral arterial disease. Next slide. So this serves as a great example, a visual representation of the procedure. So in total, there were 285 participants who were randomly assigned into 2 study arms. Both groups received pre-dilation to a point of a certain diameter, and then either received the drug-coated balloon or the uncoated balloon after that. Regardless of the randomization, the same diameter balloon that they used for the pre-dilation in that specific patient was used for the second balloon as well. Next slide. There was no scheduled fistulography or ultrasound except at 6 months. However, if some clinical issues prompted follow-up earlier than that, patients were able to come in and be evaluated across the 23 institutions. Aside from this 6-month time point, follow-up was done via telephone during the first month, and then every 3 months for a period of 2 years after the procedure. Next slide.
So with regards to the primary outcomes, which was target lesion primary patency or TLPP, the study did not meet its primary endpoint of TLPP being significantly improved in the drug-coated balloon group at 6 months. However, there was a trend of TLPP being improved in the drug-coated balloon group at 9 months. About 58% of patients had a target lesion patency in the drug-coated balloon group versus 46% in the control group. And this is just a Kaplan-Meier survival analysis. Essentially, the y-axis is just survival probability, or in this case, the percentage of patients in each group that have a target lesion that is patent, and the x-axis is time. So it essentially just goes up to the study time period of 2 years. Next slide, please. So with regards to secondary outcomes, as mentioned previously, the study specifically looked at access circuit primary patency and secondary patency. And really there wasn't any differences in the results of access circuit primary and secondary patency between the drug-coated balloon group and the control. And again, these are just two Kaplan-Meier curves, essentially showing survival probability on the y-axis, time on the x-axis. And really, it's not surprising that we don't see a difference in the access circuit primary patency, as only one specific lesion was treated with a drug-coated balloon in any AV circuit as a part of the experimental design. However, there could have been other lesions that could have developed during the study that were untreated that really could have resulted in decreased access circuit primary patency. So although the access circuit primary patency did not differ significantly between the two groups, this result isn't really that surprising. Next slide, please. So more secondary outcomes. The study looked at the number of interventions needed to actually maintain target lesion primary patency, and this result was significant such that there was actually significantly fewer interventions needed to maintain patency in the drug-coated balloon group at 9 months. However, although this is significant statistically, there really isn't a whole lot of clinical relevance, especially since at 9 months, only 0.5 interventions were needed to maintain patency in the drug-coated balloon group versus 0.7 interventions in 9 months. And this result doesn't really carry on to the full extent of the study period. It doesn't carry on into 24 months. So really, although there is a significant result statistically, really it doesn't impact clinical practice all too much. Next slide, please. And more secondary outcomes. However, this result was particularly interesting in the sense that the study also measured the mean time for an event to affect target lesion primary patency, especially in patients that actually had an event such as a thrombosis within the AV access circuit. And really at the end of a study period within 24 months, as you can see in the table, the mean time to event was significantly longer in the drug-coated balloon group at the end of the study versus the control group. And really the prolongation of time was very significant because it really extended that time to a re-intervention by about 114 days within that 2-year period. Next slide, please. And the study also looked at safety outcomes, and the study met its non-inferiority endpoint, which was freedom for any adverse event at 30 days. There wasn't any differences in adverse events between the drug-coated balloon group and the control group. In addition, primary safety events were also similar between male and female patients, and mortality at the end of 2 years were similar between both of the groups, with about 23% mortality rate in the DCB group versus 18% mortality in the control group. Next slide, please. And the study had a few important limitations that we have to touch on. First of all, the clinical teams were not blinded to the actual devices used during the interventions, and this was almost unavoidable. In addition, PTA-based vessel preparation, as defined in the study design, may have actually biased the study in favor of the control arm, as essentially in the control arm, there were essentially 2 passes of balloon angioplasty that may have actually improved the results in the control arm. However, although this may be the case, this actually might not be a limitation, considering the point of the entire study was to actually look at if paclitaxel actually helps And really, it didn't look at if a second inflation or a second angioplasty would be helpful in improving patency. So really, if a second angioplasty pass is helpful, then really it's a good thing for a lot of these patients, and really presents another cheap way to improve patency within AV access circuits. In addition, there weren't any standardization between surveillance methodology and thresholds for actually obtaining imaging, because it wasn't standardized across a lot of the study centers. And as a result, intervention thresholds may have varied between all of the interventions. In addition, antiplatelet use was not controlled, and flow measurement was not also consistently performed, which may have reduced the amount of objective referrals that a lot of investigators would have used to really bring patients back in for a repeat intervention. Next slide, please. However, although we touched on some of those limitations, we also have to look at some of the strengths that this study also presented. This was the first large multi-centered randomized trial to actually report 2-year results of drug-coated balloon angioplasty in any type of AV access circuit. Specifically, this was the first large multi-center trial to study DCBs specifically in AV fistulas. And this was a study that also looked at a specific device, the Lutonix 035 drug-coated balloon. And this was one of the only Paclitaxel-Coated balloon angioplasty devices actually approved for AV access available in the US. However, more importantly, the study really builds on the growing data and evidence for the use of DCBs in AV access circuits. Next slide, please. And so really at the end of the day, just summarizing all of the results of the study, the use of a drug-coated balloon in a dysfunctional arm AV fistula resulted in improved patency trend at 9 months. However, the study did not meet its primary endpoint of target lesion primary patency at 6 months. And although drug-coated balloon use in the study reduced the number of interventions needed to maintain target lesion patency, this result wasn't clinically significant, as really it was only 0.5 interventions needed to maintain patency in the drug-coated balloon group versus 0.7. And the result, as I mentioned previously, did not remain significant over the course of 24 months in the study period. In addition, there was a significant prolongation of time to the next intervention needed at the target lesion over the study period, and this reduction amounted to about 4 months. And this result in particular was very interesting and very clinically relevant, as a lot of these patients with ESRD really have increased mortality and decreased lifespan. And really, if you extend the time needed for a repeat intervention by about 4 months, you're really improving the quality of life for a lot of these patients. In addition, with regards to safety, the 2-year mortality rate were similar between the drug-coated balloon group and the control group, and really was consistent, and if not improved, compared to that of current mortality rates out there in the US renal data system. In addition, at the end of the day, this study really supported a lot of the small single-centered RCTs that have shown the benefit of drug-coated balloon use over just plain balloon angioplasty in AV grafts and fistulas. And really, there's some evidence out there that really kind of points to the future of drug-coated balloons and really being preferred for lesions that may be unsuitable for treatment with a stent graft and not really amenable to any type of surgical intervention. And in addition, although in this study, there wasn't that amount of clinical relevance with regards to the reduced number of re-interventions needed to maintain patency, it does present an interesting thought that maybe drug-coated balloon technology bigger trials with a lot more patients to really next slide, please. And so here we have a bunch of questions for Dr. Frenk, and I'll go ahead and pass it on to Jay, who will start out with the first question.
Oh, Zuby, right?
Or sorry,
yeah.
Zuby.
I'll start off, no worries. So Dr. Frenk, thank you again for being here. We love your expertise on answering some of these questions we had. One of them was, have you used any drug-coated balloons on practice and what to use them for? And then also, could you speak a little bit about cost effectiveness and how you use that within your practice when you're using materials such
Sorry. So thanks for the question and thanks for the invitation again. I think you guys did a great job explaining, the basics of dialysis access and discussing the paper. So good job with that. Now going to the question, it's interesting and it's kind of funny that, of all papers you asked me to discuss, you brought this up because I actually was a fellow while they were doing some of the procedures for the study, and actually they were Mass General was one of the sites. So I remember my attending that was the investigator for our institution, going through the steps of being part of the project, having to travel to see all the the demonstrations and the training, and coming back and enrolling patients. And we didn't have too many patients, but I was part of the procedures in some of them, and it just kind of really makes you realize what a big endeavor it is to run randomized controlled trials, and even just being a site, so much less to be the coordinator side and the PI and things like that. So even though the study is not anywhere huge like oncology trials tend to be, it's it's a decent sized study, and making it happen is says a lot about the great group that was behind it. So in my practice, we don't do a lot of dialysis access at Georgetown, but I've done a bunch of them throughout training, and when I was at Mass General, then at Hospital Center, and every now and then at Georgetown. To be very honest, even though this study I think was the basis for the approval, is it demonstrated the safety and maybe some potential benefit with drug-coated balloon. I think you'd say that in most places, drug-coated balloons have not really replaced plain angioplasty, right? So bare balloons angioplasty in the management of patients with dialysis access. And I think there's multiple reasons for that. I think, it's still a somewhat recent development. So even though there's, a growing body of data, there's not, that many big studies. There seems to be some benefit to it, right? I think there's, depending on how you present it, it does show like lesions treated with drug-coated balloons are less likely to restenosis so soon, but it doesn't it doesn't seem like it's a huge difference in at least not in terms of many months or many years. And all these drug-coated balloons are more expensive than plain balloons, and there's no differential reimbursement for those. So the truth is that even as much as we would love to spare patients extra procedures, at this point, if insurance don't pay you extra for the balloons, if you do a procedure and you spend more and you don't necessarily guarantee much better outcome, it's hard to justify using it, for every single lesion, which is probably what the developers of this balloon would love for us to do. I think at this point, most people tend to save it for specific situations. For example, lesions that have been treated already and that recur very soon. And at that point, potentially trying to buy themselves some more time before patients have to come back again for a third or fourth treatment of that same lesion.
Thank you, Dr. Frenk. For the second question that we kind of were discussing amongst ourselves was, if you look at the fine prints of the article, all three authors are paid consultants for Bard Peripheral Vascular, who are the makers of this Lutonix drug-coated balloons. Do you think this has any kind of impact on this trial? If so, how?
So, you're obviously bringing a good point, right? Unfortunately, most trials or most big trials in medicine are, industry sponsored because it is very expensive. The industry has the the reasoning to fund them, right? So they can get their products out in the market, but it's hard to say that there's no biases whatsoever, right? Obviously, there's no reason to think that anyone has manipulated results because of those conflicts of interest, but we're all humans, right? So we're all always, as IRs, we like to find new things that work, new things that help our patients. Either we tend to think of new developments are more likely to be better than old developments just because they're new, just because they're more exciting, they're more interesting, and because we always want to do better for our patients, right? So we always have this tendency to look at things and look at results with this, oh, this probably works, right? And when you have something like this, the presentation really changes how you can really change the focus of your presentation because of those different biases, right? So it's one thing to say, look at this study's data and say, the primary endpoint, which was the target lesion primary patency in 6 months, was the same. So there's no statistical significant difference. So this trial was negative, and so it's a negative trial. Versus, really trying to look at all the different endpoints and trying to figure out how we can present it in a way that looks more interesting, right? I think there's a very good chance that the rate of stenosis is lower with the drug-coated balloons, but is it huge? Do we need to use it for everyone, or do we need to think about specific situations where that becomes more meaningful? And having all those biases, including the financial biases, are potentially affect how we describe the results, of any study, to be honest.
Thank you so much. The next two questions go kind of hand in hand. Number one, although the Lutonix trial was kind of the first trial that studied drug-coated balloons, especially in a multi-center trial setting, there have been other trials that have come out afterwards that kind of have showed positive results meeting their specific endpoint. How do you kind of see the potential use of drug-coated balloons evolving, especially in future practice, in spite of all these conflicting trial results? And in addition, a lot of these trials have specific techniques that they used. Do you believe that there may be some issues with regards to translating some of the trial results into clinical practice, especially since real-world practice may not represent a lot of what's used in the actual trial?
So those are very good questions. I think from the technical standpoint, I think it's a little easier. In general, we tend to, whenever we're using a device, we try to do to follow the IFU as close to it as we can within reason, right? So, all this whole thing about the vessel preparation and, doing the full-time inflation with the drug-coated balloon, all those things are things that in real life we do try to follow, right? I think the vessel preparation is important because if you think about the lesion that, it's very severely stenotic, and you use a balloon, you open it up, and immediately as you remove the balloon, the lesion has restenosed right in front of your eyes, then you need to understand that, for example, using a drug-coated balloon and trying to prevent restenosis is not going to fix the problem, right? Because that lesion is just recalcitrant or very, either very tight, or is just there's so much tension and elasticity that it just won't stay open, right? So it's not about relying in the endothelial response to prevent stenosis that's going to give them that lesion a better prognosis. If it's a lesion that doesn't stay open with that initial balloon dilatation, you're probably going to have to consider putting a stent and some scaffolding to keep it open, or potentially using a bigger balloon or things like that. So that initial angioplasty that, in this case, we're calling vessel preparation, it's part of what you need to do before you decide what's going to be the long-term solution in terms of whether it's just plain angioplasty, that's all you need, versus drug-eluting stent if you're drug-eluting balloon because you're worried that that's a lesion that's going to restenose very quickly with intimal hyperplasia, versus is a lesion that's not going to stay open that you need to put a stent. And the issue with the timing, it's important because the different studies and the different in vitro tests show that if you take too long to get the balloon to the lesion, you lose some of the drug in the circulation. and it takes some time to get the balloon in touch with endothelium to actually deliver the treatment dose. So all those things affect how much drug you're actually delivering. So in general, we try to follow that as close as we can. In terms of, what's coming next in terms of future in clinical practice and how different practices are going to work, I think it's a work in progress. I think that at this point in time, just based on reimbursement issues, I think it's unlikely that this becomes the mainstay of treatment for dialysis access. I know, like you mentioned, there's other balloons in the market, there's other studies, and some might do better than others, but also studies need to be replicated to be fully respected. I think there's still more to come. I think there's also the questioning about, are all drug-eluting balloons the same, right? So different balloons have different doses of paclitaxel that potentially make a big difference. Different technologies have different paclitaxel-eluting mediums that keep the paclitaxel attached to the balloon and that take part in the process of transferring the drug from the balloon to the endothelium. And as far as we know, this could make a huge difference in the effects in that lesion there, in potentially in downstream embolization and effects in the distal capillary bed. So at this point, we call them all drug-eluting balloons, drug-eluting stents, drug-eluting technology, but I think there's still much to be learned about those in terms of the best situations where they can use. Then, is everything, are they all the same, or are we just, talking about completely different results based on different technologies?
Thank you so much, Dr. Frenk. I think those were the questions that we kind of prepared in advance for Dr. Frenk, but if there's any other questions from you guys on this call, we would be happy to answer them for you guys.
Hi, Dr. Frenk. Thanks so much for coming. I just have a question about more of like the technical aspect of deploying the balloon. So as you mentioned, it's sort of like, it's by contact that the paclitaxel is actually delivered to the endothelium. Is the drug actually exposed during the whole time while you're navigating to the fistula? So such that like if someone had very complicated anatomy or if there was a problem, it would actually cause less paclitaxel to be absorbed by the endothelium?
Yeah, so that's a very good point, and it's exactly what you said, right? So as soon as the balloon gets inside the blood vessel in the circulation, you start losing some of that drug to the blood. And so basically, there's, different IFUs will tell you that there's a maximum transit time that you need to follow from the entry point of the balloon in the blood vessel until you get to your lesion and you start the inflation. For dialysis access, that's not a big deal because, if you think about it, we're getting in the wrist or in the, at the cubital region to treat a lesion that's here. There's a very short length. It's usually just a straight segment. But when you're using those balloons to treat, lower extremity arteries, you might be coming from the wrist or from the other groin and going up and over, and then it becomes a bigger deal. But that's definitely something that, we need to kind of be mindful of. And it starts from when you're handling the balloon, avoiding touching the balloon directly, so you don't, remove some of the drug inadvertently. And as soon as you get into the blood vessel, you start a timer and you try to move as fast as you can. And for the same reason, you use the balloon, you treat a lesion, and if you have another lesion, then in general, you need to get another balloon, which adds to the cost because you've run out of drug from the balloon.
I think Zuby was talking about that it changed from 30 seconds to 2 minutes. Is that pretty normal to have like a big range in how long you need to actually have the balloon up for? So
for drug-eluting balloons, we pretty much follow the IFUs, and they adjusted the IFU from that shorter inflation to 2 or 3 minutes, exactly to maximize the drug delivery. For non-drug-eluting technology, there's some data that says that longer inflations might help with decreasing the wrist stenosis, but it's a little bit of operator dependent. So some people are more patient than others, and I think there's not amazing data that suggests that makes a big difference. I think there's some more people are more likely to leave balloons inflated for a very long time when they're dealing with chronically occluded veins and trying to, really gain area. But in other situations, people, leave it like for 30 seconds and take it out. It really depends on the person and how they were trained, to be very honest.
Great, thank you so much.
Of course.
Any other questions from the audience? Awesome. So these were some of the references that we use besides the actual article itself. And I believe that marks the end of our journal club for this month. Thank you everyone for attending, and especially Dr. Frenk, thank you for joining us with your expertise.
My pleasure. I had a good time. You guys did a great job there. And good luck with everything. If anyone ever has any questions, feel free to reach out to me.
Got it. I could send out Dr. Frank's email to this chat. And everyone, have a great Thanksgiving and see you guys next time.
Take care.